Welcome back to Search Ahead. During the research for these videos, I came across with a term that I've never seen before, which was medical geography. As I am a very curious person by nature, I decided to find someone who could tell us more about it. That's why we're going to be talking today to Arrianna Marie Planey. She's an assistant professor in the Department of Health Policy and Management in the Gillings School of Public Global Health at the University of North Carolina in Chapel Hill. Thank you very much for being with us today. How are you?
Thank you for having me. Things are well here. I hope all is well for you as well.
I think we have to start from the very beginning and ask, what is medical geography?
So health and medical geography, the simplest definition I can give is it's the study of the relationship between health and place. And you can think of health in the broadest sense. It can be health outcomes, it can be experiences of health and well-being, and it also relates to services and community assets, however you want to look at it, that enable health and well-being. So that can include healthcare, social services, social policies. So in a broader sense, health and medical geographers study the interaction between health and places, and also how place characteristics influence health and well-being, but also how health and well-being also shapes places. Because you can think about ways that we kind of build in our broader sense of health and well-being into our daily life activities, like recreational spaces. So when, for example, planning, and in some places they do, there's an explicit prioritization of public spaces that allow people to be social, but also to engage in recreational activity. Whereas there's more and more places that do not. And that does affect our health. That affects, say, for example, our ability to enjoy being out in public, our experiences of what a public place is, or even a perception of who is allowed in a public place. And a good example of this is when places are not accessible to people who have disabilities. The implicit message is that people who are disabled don't belong in those places, or don't belong in that society, because the public spaces in that society are not accessible to them. I fall within the quantitative geography tradition, tradition within health geography, which primarily applies spatial epidemiology, spatial analytic, spatial statistical approaches to study the relationship between health and place. And there's a lot of ways we can do that. So that's one way. That's one thing I love about geography, just that you can study the same thing in so many different ways, because there's so many tools at our disposal and so many different ways of asking and answering questions.
Thanks very much for the explanation. I think now I have it a little more clear. You have written on rural hospital closures and accessibility to healthcare, but I would like to know, how is medical geography connected to our work referring to the global lack of access to safe surgery in rural areas?
It's so connected. I don't have to say I couldn't give proper credit or proper due, but there are medical geographers who already do work in this area, and there's also a great diversity, or sort of great range in the work on health and on medical geography on the continent. There are quantitative studies that look at travel distance needed to travel distance to needed care from remote places and places, I've seen studies in Tanzania, Zambia, but they do ask very practical questions and apply these methods so that they can inform intervention to, say, make prenatal care more accessible or address underlying factors that drive, say, pregnancy-related and birth outcomes observed among, say, women in a given community. So like that can include addressing factors such as nutritional deficiencies, preeclampsia, or even interventions that can help prevent preterm birth or low birth weight, which is associated with one of the biggest causes of infant mortality outside of infectious disease. A lot of medical geography is centered on facilities, so like healthcare facilities where services are provided. So like one way we can think about it is healthcare provision always has a territorial basis because there's always going to be a decision about where to place a facility, where healthcare workers will work, because they don't always work in a facility. Sometimes they go from village to village or community to community. But those are geographic decisions, and it helps to have decision-making tools to inform those decisions. It also helps to have analyses of inequities to inform this of like where you choose to intervene. We can think of healthcare services, healthcare facilities as resources. Where they're located geographically or spatially, it's always a political decision. And if that decision isn't made without explicitly considering sort of how health and well-being is distributed in a population across space, it's going to reinforce inequities. So like in terms of global health, we can see a lot of inequities that just kind of are reinforced just because especially when a lot of the major decision makers the major stakeholders are people outside of a country or outside of a community. So they might make a decision that's convenient for the workers who are coming in from outside of the community or from outside of a country, or people who may not even speak the language of that the patient that they would be serving speak. So it's sort of misaligned, I guess, interest in some way, because it's not enough to have good intentions. It's that what we do needs to be guided by with sort of an equity lens, understanding that if there's an equity to begin with, and we're actively working to sort of reduce that inequity or offset it, then no matter what good we do, we're still going. It's going to be like trying to empty the ocean with a pail.
Thank you. This is it's great to have your insights on that, and it is very noticeable, not just during this conversation and your answers, but also reading your work, that equity is a constant and a very strong element that appears and is cross-cutting in your interests. What is your personal experience in the field of research regarding equity?
So, yeah, I would say yes, I agree that equity is at the core of my work. I try to keep it at the core of my work. I'm always trying to align the questions I ask with the principle of equity, that the allocation of resources should produce more equitable outcomes and not just equality, like equality in terms of who has what, but also equality of outcome.
Yeah.
So, and I'm just going to draw from my notes here, but my idea was that if I'm going to do work that's consequential and relevant as a researcher, I need to start with a guiding principle that keeps me grounded rather than just being guided by data or methods that I have at my disposal. So that's one thing I'm doing is I'm always trying to read and learn more about both the subject matter and the method so that I can ask better questions, but also address more questions with the tools I have. So my experience with equity in the field of research is that it can be hard to center equity in research questions when the incentive is to publish more and more and more. And it's easy to churn out a cross-sectional linear regression model that doesn't really answer a question that matters, but it's just using unavailable data. So it's easy to do that, and I see why people do it because it's very highly incentivized to have research output, but it's not the incentive. There are no similar incentives for asking and answering questions that have immediate relevance to our everyday lives, or the everyday lives of people who are most marginalized in our communities and around the world. I mean, we see this already with the vast majority of research is carried out in the global north. And even when you look at research conducted on the continent of Africa, like there was a paper that just came out a couple of weeks ago, they found that in economics journals, most studies set on the continent of Africa were something like 80% or more were set in English-speaking countries, and Kenya was number one. And I'm pretty sure there's a similar bias in like global health research and surgery research, but it's, well, one, it reflects who has access to university, who has access to the resources to do this research, and who's able to get published in these journals. But it also, in the same way, it does reflect who doesn't have access to those resources.
Thank you very much for having found the time to be with us, and thank you for explaining what medical geography is. We wish you all the best.
Yeah, all the best to you.
Thank you.
All right.
And for all of you, thank you very much for having watched this video. We have the rest of conversations in our section Search Ahead that you can find on our website. And also you can just be updated with the latest news and work on our social media, Twitter, Facebook, YouTube, Instagram, you name it. Take care and keep yourselves safe.